An overview of population health. This presentation is brought to you by a collaboration between the Rocky Mountain Public Health Training Center and the Wyoming Institute of Population Health. The institute was created to foster partnerships between care delivery systems and public health as they work side by side to meet key tenets of healthcare reform and essential health services. The most important element of healthcare reform is playing out in communities, in partnership with hospitals, providers, and public health organizations, all of which are closer to the people and the problems causing poor health and lack of access to quality, affordable care. Why should the public health workforce be interested in population health? The intersection between the care delivery system and public health to address essential health services are nearly countless, but include the following: assuring access to quality care, extending the provision of health care when otherwise unavailable through requirements to report charity care and support safety net services that link people to not only personal health services, but also to health-related social services. Monitoring and investigating, and then informing, educating, mobilizing, and empowering the care delivery system, public health, and community coalitions to effectively intervene. Researching and promoting innovative models of personal and population-based health services. Ensuring and developing a competent workforce, hospitals and providers who deliver care at the community level and foster the willingness to test care delivery improvements that emphasize wellness, prevention, and care management for their most complex patients, moving away from volume-driven healthcare delivery and toward value-added care. After completion of this module, the participant will be able to define how the current reformed payment incentives in healthcare are driving changes in the way that care is delivered, describe a broad definition of population health, examine how a population health perspective integrates public health and community services, and describe a medical neighborhood model. Hospitals and healthcare systems are facing unprecedented pressure to change because of multiple and intersecting external forces like an aging population and an unsustainable rise in healthcare spending. What some now refer to as the good old days was a volume-based reimbursement model. Payments were made based on how much service was provided, so we provided a lot. Much of the care was hospital-based and ended at discharge. Health information technology spending decisions were made based on the least amount that would be necessary to spend, and were often several legacy systems cobbled together. With the 2010 passage of the Patient Protection and Affordable Care Act, healthcare was presented with a new challenge, moving from payment for volume, traditional fee-for-service, to payment for value. With the Affordable Care Act, many healthcare providers began to experience the discomfort of living in the gap. They could see the change was coming, and many believed it was necessary, but much of the transformation was viewed as demand destruction chronic conditions managed more optimally and resulting in less clinical emergencies in the care of patients. Between passage of healthcare reform and today, that gap has narrowed significantly. Payment is already transforming healthcare delivery and financing from volume to value-based payments, and the need to address reformed payment incentives will drive a change in the way that care is delivered. Let's take a closer look at this model. The first curve represents the way care in the U.S. has historically been organized around fee-for-service, or volume-based environment. Healthcare was oriented on delivering more volumes of service, often resulting in large volumes of repeated diagnostic services, not directly benefiting the health of the patient. Care was characterized by poor alignment, care that was fragmented and hospital-centric, lack of communication between providers, complicated closed systems that were difficult for patients to navigate, inconsistent quality or little being known about the quality of primary care, frequent failure to address the social or basic needs of the vulnerable patients, difficulty in accessing primary care, almost non-existent payer partnerships. Payers have lacked the data needed to inform change. Health information, when it did follow the patient across care settings, was often substantially delayed, causing patient confusion and, all too often, duplicated services. What we are describing is the acute care hospital of the past. Episodic care and poorly coordinated chronic care management have been the status quo for several decades. The patient is admitted and services are focused on the specific diagnosis. Let's take a closer look at this. Meet Victor, a 55-year-old male who works temporary and part-time positions that offer inconsistent or no health insurance. For recreation, Victor and his wife like to pitch a tent at a nearby lake and fish. Victor was having some problems with fatigue and frequent urination that were keeping him from enjoying these outings, so he visited his doctor and was subsequently diagnosed with type 2 diabetes. His doctor gave him a prescription for medication, which Victor then had filled at the pharmacy. Victor took his medication but ended up in the emergency room, presenting with symptoms of elevated blood pressure and blood sugar. He was treated and sent home, only to return to the emergency room a few months later for the same issue. This cycle continued. Something wasn't working, but the old system had no mechanism by which to discover what was going wrong and why this pattern was being continually repeated. Now, let's look at the second curve, the way care is starting to be delivered. In the second curve, payment is driven by performance based on improvements in clinical health outcomes. Value-based reimbursement payment rewards reductions in hospital-acquired conditions, readmissions, and adoption of meaningful outcome measures and physician quality reporting. Value-based reimbursement rewards enhanced care along a continuum of care that is interested in enabling patients via disease knowledge and disease management skills to partner with their physicians in improving their care. The second curve emphasizes wellness and prevention instead of the traditional illness model, call us when you need us. We must begin to celebrate avoiding emergency rooms, hospital readmissions, reduction of service duplication, and over-testing. In the second curve, payment is based on improved patient outcomes and patient satisfaction. The second curve is focused on providing the right care at the right time in the right place. It includes coordinating care, managing transitions across multiple settings along the healthcare continuum, and supporting increased understanding of effective self-care. This new model of healthcare focuses on linking vulnerable and high-risk patients with aligned community-based, health-related social services. Let's start with a common definition. At its most basic, population health involves improving the health status of a given population by ensuring that members of the population are receiving the healthcare that they should be receiving. Said another way, population health means looking at the person behind the patient, looking at the environment in which they live and the challenges they have to overcome to become producers of their own health, not just passive consumers of healthcare services. How is this done? First, we must know what care the population is receiving. Next, we need to identify the gaps by comparing the care the population is receiving with the care that the population should be getting. Finally, the care delivery system must be able to address these gaps in care. Population health has been called a must-do strategy for hospitals and healthcare systems. So how do we get there? Here's a framework for health system transformation in this new environment. We've discussed the acute care hospital of the past, where we saw episodic healthcare, limited integration across care networks, and a lack of quality with poor chronic care management. Let's take a look at the next step in the continuum. Coordinated, seamless delivery system that focuses on patient and family-centered care. In this model, we see improved access to primary and preventative care services, a focus on care management and transitions, and on communication across sites. The old model of healthcare delivery cannot be sustained, based on the fact that the United States spends the most per capita on healthcare cost, but only ranks number 11 in terms of clinical outcomes. We are not efficient in providing healthcare services to our population, which begs the question, how do we improve? The answer lies in a fundamental change which puts the patient in the position of being supported instead of just being treated. The care delivery system now works to understand how the care team can engage targeted groups of patients in ongoing chronic care management and preventive care, evaluates opportunities to improve patient engagement during specific episodes of care across treatment and recovery, deliberately explores the role of the health system in long-term population health through partnerships with public health and other community health stakeholders. In Victor's situation, the hospital has incorporated a diabetes management group to support patients as they work to keep their disease under control. This group is run by a registered dietitian and nurse, and Victor is provided a referral to a group through a social worker when he is discharged. Victor is also given the name of a group that helps underinsured individuals who need ongoing medication to manage chronic health conditions. The health system is starting to take a broader look at Victor and consider non-acute care services extending outside the hospital walls. This allows for the support of Victor in remaining healthy with his diabetes well managed. Though this is an improvement from a health system that only provided acute and episodic care, some limitations remain. Victor is referred to other resources upon discharge, but he may be left feeling lost in a maze, not fully understanding where to go for what kind of help, or he may not follow through with accessing the resources after he leaves the hospital. We need to go further to truly address population health and to provide Victor with the best opportunities for sustained health. The care delivery system redesign has placed strong emphasis on prevention and proactive management of disease conditions, while maintaining the focus on the health improvement objectives set forth by the Institute of Medicine in 2001. The new vision for healthcare delivery creates a framework that allows health improvement for strategic improvement in the quality of care. Yet real breakthrough has only been possible where population health management has been incorporated into the framework. Hospitals must now play a more prominent role in care management, disease prevention, health promotion, and linking patients with needed psychosocial and economic supports within the community. This framework expands and redesigns the relationship between patient-centered healthcare delivery and powerful community allies of health promotion and education, such as public health and social service organizations and critical resources. What if a health system took a truly people-centered approach? What if a health system had the resources and took the time to support a patient through the transitions of care and help them navigate the resources available to support disease management? What if time was taken to engage a patient in becoming the driver of his or her own care? What if the focus was on keeping people well and not just treating them when they're sick? Victor is now at the center of a new model which has major implications for healthcare provided across the continuum. This means that it is not just the healthcare provider determining treatment options for the patient, but a collaborative approach that utilizes the patient, the full care team, and the family members or appropriate caregivers, so that the patient is the driver of the care he or she receives. It is important to understand that this model focuses on coordination within the care team. The patient should see a seamless flow of information with strong communication between all of the partners providing care and resources. Thanks to increased communication with the patient and better coordination between the various entities providing care for Victor, it is discovered that diet is playing a significant role in Victor's repeat visits to the emergency room. Although he is taking his medication, his diet is not supporting optimal regulation of his blood sugar levels. We are now seeing more of the picture and getting closer to improving health outcomes for Victor. Increased communication and a people-centered approach also reveals Victor and his wife's love of camping and fishing, something they haven't been able to do as much since Victor's health has gotten worse. The care team is now able to focus on patient-defined outcomes that will motivate him to be an active player in his health. Victor may take a medication because his doctor tells him to, but he is more likely to engage in healthy lifestyle changes that improve diet and exercise if he is personally motivated, not by a desire to keep his blood sugar down, but by a desire to go camping with his wife. Victor's issues with his diet are not completely within his control. Victor is experiencing food insecurity and frequently relies on the local food bank. the box of food he received from the food bank tended to be carbohydrate heavy and unsuitable for a diabetic patient. Hence, Victor had trouble maintaining his blood sugar levels and, again, made repeat visits to the emergency room. With a community integration lens for healthcare, there is communication with the food bank to ensure that a diabetic-friendly food box could be provided to Victor and others like him. Coordination with public health departments, support groups, housing and financial assistance agencies, and other social service organizations becomes part of the new model for healthcare. The true population health management paradigm takes a holistic view of the healthcare sector working within the resources of community and public health. An informed, active, and health-wise citizen enters a strong participatory relationship with his providers. A fully engaged patient partners with his providers in creating a plan of care and a path of recovery post-clinical treatment. Population health is the vehicle to operationalize the intersection between the healthcare sector and community public health resources to improve health. As population health progresses toward full maturity, the hospital becomes just one piece that makes up the full system. As we see here, the health system now is an integral part of the community with support services building around it. The patient will begin to see that genuine care is not just about a hospital stay, rather the support for healing and wellness that comes outside of the traditional four walls of the hospital. One of the most important aspects of population health transformation is the need for an activated community, which includes the informed patient and how these patients interact with the proactive practice team within a prepared community. An activated and prepared community includes resources and services available for patient access to assist in general health achievement and maintenance. Access to public health services such as immunization and flu clinics, maternal and child health services including contraception, HIV clinics, emergency response, environmental health and safety, food and drinking water safety, food and restaurant safety, etc., set the standard in healthy and prepared communities. It can be argued that this step is the most advanced segment of population health management in that it shows the acceptance of the new healthcare paradigm. The driver is no longer the provider, it is now the patient, and a balance of evidence-based care with patient preferences, expectations, and goals. There are challenges in this segment of population health, but we are seeing constant advances as healthcare delivery focuses on patient-defined outcomes. When combined, the medical neighborhood emerges utilizing a patient-centered approach, an integration of the health system with community and strong partnerships between the patient, family, and care providers. Through this work, population health management becomes a very practical model that works toward the best outcomes for the patient in the most efficient ways possible.